Good afternoon, and welcome to our webcast for the Methodist DeBakey Cardiovascular Journal. I am Miguel Quiñones, the editor-in-chief of the journal, and I'm delighted to be here today discussing a topic that is not what we commonly as clinicians are used to learning about. As you know, the journal concentrates frequently in clinical topics, but once in a while, it's kind of good to get into a little bit more basic science, particularly in areas that are developing and have a lot of promise to help us in the future take care of patients. So because we have an outstanding investigator in the Methodist DeBakey Cardiovascular Institute, Dr. John Cooke, sitting on my right, John very nicely accepted the task of being the guest editor for the issue that was published just a few weeks ago in the journal on cardiac regeneration. And that's an area that, again, has been going around for years. We all have been hearing about stem cells, trying to regrow the heart. And in fact, as clinicians, we often use the term recovery and regeneration as kind of similar, and not understanding exactly what they mean. So as I welcome Dr. Cooke, who is, by the way, the Joseph and Carol Walter Luke Presidential Distinguished Chair in Cardiovascular Research, and also the chair of the Department of Cardiovascular Sciences for the Heart Center. But John, just to start with, help us understand what is the difference between recovery of the heart and regeneration of the heart. Mm-hmm. Are they similar? Are they the same? Or what's about it?
Well, first of all, Mike, thanks for having me on your show, and thanks for asking me to be the editor of that issue. I really had a lot of fun with it, and we have some excellent people writing for that issue, and I urge everyone to take a look at it because it's really quite well done.
Yeah, actually, I want to tell the viewers that as a clinician, if you want to have one place where you can read and learn what is hot in this area, this is it. This is it. So we want to really encourage all of you, listen to the webcast, get a little bit of a few educational tips, but go to the journal and read it because it will really help understand much better how this field is growing.
So you asked me a question about regeneration versus recovery. So recovery, the way I think of recovery is that it is a restoration of function. And as a clinician, I think of patients that have had an ischemic event, like a coronary artery occlusion, but then if it were revascularized with a balloon angioplasty and stenting, and now their arteries open. Well, they did have an injury to the heart. And they may have some hibernating myocardium or stunned myocardium. But over time, we see those patients sometimes fully recover their ventricular function, right? That's recovery.
Okay, so when I have a patient that comes with a cardiomyopathy, EF of 25%, we treat them with all the good stuff that we have available this day, and 6 months later, their EF is 60%. Again, that would be recovery.
I think that's largely recovery, Mike. You know, I do believe that to be the case. However, there may also be some regeneration going on. And now regeneration is different than recovery, because regeneration is actually cardiomyocyte proliferation, perhaps even vascular proliferation. So more new tissue that is contributing now to the improved function of the heart. So that's how I think of the difference.
So regeneration is growing new tissue.
I believe so.
So regeneration of the heart will be growing new heart.
Yeah.
So really, I mean, this science fiction, mysterious, aesthetical things, or is it really happening?
Well, if your question is cardiac regeneration possible?
Yeah.
I unequivocally yes. Unequivocally yes. If you're talking about lower vertebrates, if you're talking about zebrafish and amphibians, they can regenerate their heart. It's been documented multiple times. So they have a tremendous capacity to regenerate the heart. So you can snip off a third of the apex of the zebrafish heart, and the zebrafish is able to regenerate the entire ventricle without a scar,
without
normal tissue.
Wow.
And so too can other lower vertebrates, amphibians and such. Now here's the interesting thing. it's also possible in people, in babies. So there's some evidence that early on in the prenatal state, mammals, like mice, can regenerate the heart. They lose that capacity very soon after birth. The cardiothoracic surgeons that are operating on kids tell me when those intrautero. Okay, so they're doing intrautero surgery.
Yeah.
They open up the heart of that child, that fetus, and correct the life-threatening cardiac abnormality. When those children are born, they don't have a scar on their chest. So scarless healing is possible very early in our lives, but we lose it rapidly after birth.
We lose it. So
Now,
if we can discover how that happens, we can then hopefully do
exactly. And in this issue, again, of your journal, we talk about the mechanism of cardiac regeneration.
All right, well, teach us something. Who else do we have here to help us with all that?
Well, maybe we'll start with Dr. Altamirano, Francisco Altamirano. Francisco is an assistant professor in our Department of Cardiovascular Sciences. And Francisco is a great basic scientist who's doing really interesting work in cardiac electrophysiology at a basic level, but also working with Dr. Valderrabano here, who's an electrophysiologist, bringing those two worlds together, the basic science and the clinical science. And one of the things you're using, first of all, Francisco, thank you for joining us today.
Thank you for the invitation.
Yeah. And I think what you talked about in this issue of the journal, you talked about how you're using iPSC-derived cardiomyocytes to study cardiac function. Tell us, what is an iPSC and how do you get heart cells from that?
Yeah, sure. So an iPS is a kind of a stem cell that we can derive from fibroblasts or a blood sample, that when you express certain proteins that are called the Yamanaka factors that were discovered by Dr. Yamanaka, and he won the Nobel Prize in 2016, I think, for discovering these. With those factors, these cells can be reprogrammed to their stem cell, and they can basically differentiate in any cell that we want. So that is why they are called induced pluripotent stem cells.
So just a question about that. So you can take a skin cell from me, put it in a dish, expose it to these Yamanaka factors, and turn it into an induced pluripotent stem cell, which can become any other cell in the body.
Yes.
Did I understand you correctly?
Yeah.
And so then you can take a skin cell from a patient, make an iPSC from induced pluripotent stem cell, and then differentiate that into heart cells.
Yes, that is correct.
Amazing.
Yeah, and kind of in the iPS in vitro, we can recreate the differentiation that happened, during development of cardiomyocytes. So first you induce like the first layers, in the embryo will be the ectoderm, mesoderm, and endoderm. You induce the mesoderm. That is the one that will generate the cardiomyocytes.
So you've got the cells growing in a dish, these induced pluripotent stem cells, and you're adding factors to the dish to push them to differentiate into something else.
Yes.
And in your case, it's a cardiomyocyte, so you're putting like different proteins in there that favor cardiomyocytes. Okay.
Exactly. So you have, these three layers of the embryo, and depending on the cell that you want to differentiate, you will push one or the other. If you want neurons, you will use layers that are ectoderm that will form neurons. If you want cardiomyocyte, you will push the mesoderm that will generate cardiomyocyte. And now there are many protocols available that using different molecules or small molecules, inhibitors, of certain or activators of certain pathways inside of the cell, and the cells can differentiate to cardiomyocyte. And those cardiomyocyte, of course, they are immature. But now everything, kind of the field is going in try to maturate them for therapy, to regenerate the heart, to test drugs, and kind of the possibilities are endless.
When you got these in the dish, are they actually beating like a heart cell?
Yes, so they contract, and it will be a monolayer of, I call them like fry eggs, because they have the shape of a fry egg. It's like they don't have the organization of an adult cardiomyocyte. An adult cardiomyocyte will be superstructured, kind of all the sarcomeres organized in the longitudinal axis to contract and transmit the force efficiently. But these cells in vitro, like in culture plates, they will be like spread on the plate like imagine a fried egg. So they kind of be in weird shapes, and they lack the structure of an adult cardiomyocyte. And that, of course, is not good because cells require that structure to work efficiently, but they are human. So it's closer to human, but still the challenge is to maturate them to become like a more mature tissue.
So they can contract and beat, but they don't do it in a really normal way. They don't look normal. Their morphology is normal. I guess they probably don't generate as much tension because their morphology is abnormal. Is that correct?
It's mostly kind of the organization of their sarcomeres and the three-dimensional structure that the heart here is like everything flat in a monolayer of cells.
Sounds pretty cool, but how do you go from a dish to a human, to a patient?
Yeah. So now, kind of like the technology is kind of evolving. So there is the option now to kind of differentiate an organoid. So maybe use like all the layers of the embryo and in vitro try to mimic a heart. And there are some publications that will generate all the chambers of the heart in vitro, and it will be kind of a tiny heart, that is in a culture dish. And the other option is to grab those cardiomyocytes and mix it with other cells that are fibroblasts, endothelial cells, and put it with collagen, extracellular matrix, and form a three-dimensional structure that over time will maturate. And now the classic method that you use is that you have two posts of silicone. You will put these cells and they will assemble a functional engineered tissue that you can use for testing. Now, for the human, it's a different thing that you will need to generate a graft, and that graft can be used to replace the damaged myocardium. The problem is that these cells are immature and they can be kind of a foci for arrhythmias, and they can kind of make the problem worse. So finding the right way to differentiate them and maturate them to implant in an injured heart, that is kind of the research now that we are trying to solve.
Can you use these cells for testing new drugs that you might want to treat a patient with? I mean, we tested drugs in animals and they seem to work, and then we get into clinical trials and they don't work, or they cause arrhythmias, they cause problems. Would this be a way to test new drug therapies?
Yeah, actually the FDA now kind of requires testing in these cells, cardiomyocyte derived from iPS, because they have human action potentials. And if you develop a drug that you want to test if will have an effect in human, mice beat their heartbeat at 600 beats per minute, so it's not good. So you use usually rabbits or pigs or dogs, but still they are not human cells.
They're not human. Yeah.
And an iPS is a human cell, but still immature. So many drugs are being tested for different diseases like long QT syndrome, that is an arrhythmia. Try to see how you can affect the action potential, and also use this platform to test safety, kind of to see if they have.
I am assuming that if the FDA is requiring that, is because already there have been shown some sort of good correlation between what you see in those cells and the potential in the humans.
I think that is what.
Because otherwise the FDA will not be pushing.
Yeah, I think that is happening. Is that this year FDA kind of before all the drugs needed to be tested in animals, now the FDA kind of released a statement that is not kind of a requirement, like still you need to do animal testing, but
sure.
The problem is that 9 out of 10 drugs that are being tested in clinical trials, they fail because they can generate an arrhythmia, and adverse effects that you won't predict if in animals. You need to test it in human cells. But the challenge is to integrate probably the research in animals and iPS, because all of them have limitations and strengths. So,
Another question that occurred to me is, can you take these iPSC-derived cardiomyocytes and learn something about pathophysiology? For example, a patient with a cardiomyopathy, and you don't understand the pathophysiology. Could you take a fibroblast, a skin cell from them, generate the iPSCs using the Yamanaka approach, differentiate those into cardiomyocytes, and then study the cardiomyocytes in addition, figure out what that pathology is?
Yeah. So now there are many publications that they will isolate these cells from patients that have mutations that drive different kind of cardiomyopathies, and then you differentiate to cardiomyocyte and you can test the function. And this is amazing because open like the door for personalized medicine and to understand, in a family that carries a mutation, what will be the impact of unknown mutations, but also to mutations that we know to kind of find therapy. So it opened new avenues for treatment.
Mm-hmm. So we already are kind of seeing a benefit of mix the dish and the human working together. That's fantastic.
Right.
Yeah,
We're able to study
there.
drugs with these cells, and we're able to get basic research insights about the pathophysiology of disease.
Okay,
Tell us about
phenomenal.
the insights that you've gotten from. What about this disease that you're studying, the the polycystic kidney disease? Tell us about that disorder.
So polycystic kidney disease is caused by mutations in polycystin 1 and 2, and is associated with renal failure. And like the dogma is that renal failure causes cardiovascular alteration in this patient. But what we found is that if you mutate polycystin 1 in cardiomyocyte, the animal will develop the same cardiac disease. You will have systolic and diastolic dysfunction that you see in patients. So deleting the protein only in the cardiomyocyte can recapitulate the alterations. So that means that the disease starts for the heart in cardiomyocyte. And this is what we are trying to study.
That's very cool. That's paradigm shifting. Because Mike and I were taught that polycystic kidney disease caused heart problems.
Right.
It caused heart problems
the
because
heart is a
renal
secondary
failure.
victim.
Yeah, exactly.
Not a primary player.
Right. The LVH, the left ventricular hypertrophy that occurs in these patients, the hypertension that occurs in these patients, they're due to this mutation affecting the cardiovascular system.
Yes, so also there is a study showing that affect endothelial cells, smooth muscle cells, the vasculature, and hypertension precedes the onset of renal failure. So kind of now clinical trials are trying to control hypertension to slow down the growth of like the renal cyst and the degeneration of the kidneys. So what we are trying to do with the IPS is mouse models, as I mentioned, they beat at 600 beats per minute. Their electrophysiology is completely different to human. So if we want to study the human disease, using these cells that are closer to humans provide an excellent platform because they express all the channels that produce this classic action potential that we study in textbooks, that this plateau and kind of all the features of human myocardium. So.
Wonderful. Thank you for that.
Thank you.
We were expecting Dan Gary to talk to us about cardiomyocyte proliferation. I don't know if he's on yet. If he's not, maybe we could turn to our other guest, Dr. Jen Chen. Dr. Chen, thank you for joining us today, and thanks for your wonderful article in the DeBakey Journal.
You're welcome, John. Thank you so much for the invitation to write this article and also join this lively discussion today. I'm learning a lot from everybody.
Thanks. And Jen, you're an associate professor now in diabetes complications and metabolism at the Beckman Research Institute at the City of Hope. And tell us a little bit first, before we delve into the science, tell us a little bit about yourself and the laboratory you run.
Of course. So as an associate professor, I've been working here at City of Hope, especially in the Diabetes Metabolism and Research Institute for the past 7 years. I was trained as a scientist in cardiology as well as in bioengineering. So I started my studies in mechanical sensing, especially endothelial cells, in response to shear stress. And then gradually my interest delved into RNAs, especially non-coding RNAs, including microRNAs and long non-coding RNAs. And then we are learning that the long non-coding RNAs, together with other modulators, play an important role in the epigenetics regulation of vascular function. So my lab at City of Hope has been really interested in identifying novel epigenetic mechanisms that contribute to or drive endothelial dysfunction and how they play a role in regulating the physiology as well as vascular and cardiovascular diseases, especially in the context of diabetes.
Mm-hmm. Great. I think There's growing evidence now that for us to understand cardiac regeneration and vascular regeneration, we really need to understand the epigenetics of that process. So start out by telling us, what is epigenetics? What does that term mean?
Okay, so I'll try to keep it short. So epigenetics, we all know about genetics, that's about DNA. And epigenetics is about the study to identify what's happening after the DNAs are made. So briefly, epigenetics investigates the changes, and they're often heritable, especially when it comes to, for example, DNA methylation. That's the first epigenetic modification that was discovered. And epigenetics also identify histone modifications, or those mediated by non-coding RNAs, including microRNAs, long non-coding RNAs, and even at the 3D chromatin remodeling conformational level. And none of these really change the DNA sequences per se, but they can have from slight to significant modifications or effect on gene expression, as well as cell function, and then the tissue phenotypes.
So the chromosome doesn't change, the DNA doesn't change per se. That doesn't change, the sequence doesn't change. But you're saying that
right.
the DNA itself can be modified, like by methylation, or it can have factors acting on it to increase expression of a gene or reduce expression of a gene. In your article in our journal, you talked about long non-coding RNA. That must mean there's also small non-coding RNA. Can you tell us the difference between what is small non-coding RNA, what are those, and what is long non-coding RNA?
Sure. So the small RNA usually refer to those that are shorter in sequence, typically microRNA and some POE RNAs. And often there are 20, no more than 30 nucleotide in length. And they often act as transcriptional or post-transcriptional modulators that affect like messenger RNA stability and the protein translational efficiency. And the long non-coding RNAs, as indicated by its name, it mainly refers to non-coding RNAs that are longer than 200 base pair or 200 nucleotide in length. And the linker RNAs can do all kinds of things. They have very diverse modes of action. They could modify the microRNA activity by being their targets. They can bind to the chromatin and interact with other epigenetic factors. For example, those that regulate DNA methylation or histone modification to affect gene transcription.
Wow, it's a lot more complicated than the way we were taught, right? We were taught DNA, RNA, protein, but there's a lot between DNA and RNA, right? You've got these epigenetic factors that are acting directly on the DNA to change the expression of the DNA, so you get different RNA and message RNA produced. And then you have the message RNA itself, you said, can be stabilized or destabilized by some of these small epigenetic factors like the microRNA. I know you've done some work with microRNA. Tell us a little bit more about how microRNA works.
So the most canonical way that microRNA works are to bind to the 3' untranslated region of a messenger RNA. And this is associated with the recruiting of RNA binding protein, especially the Argonaute protein complex. And often this can lead to messenger RNA degradation or inhibition of messenger RNA translation into protein. So typically microRNA will lead to transcriptional suppression.
Okay, great. It used to be said, I remember I heard Victor Zhao speak for the first time, it was like 30 years ago, or maybe longer, and he was talking about junk DNA, because he was referring to the fact that only 2% of our DNA in our cells actually gets transcribed into RNA, which gets translated into protein. And at that time, 30, 40 years ago, we didn't know what the other 98% of the DNA did. I never liked that idea of junk DNA. I thought there must be something more to it, because it's like, just to paraphrase Albert Einstein, God doesn't roll dice, right? and God doesn't make junk. Why would we carry around junk in our trunk, for evolutionary millions of years, right? So we now are finding, because of the work of Jen Chen and others, that so-called junk DNA actually is responsible for generating the long non-coding RNA and the small RNAs that you talked about, and those are regulators of the DNA that actually gets transcribed into RNA. So okay, so let's get to what you talked about in your chapter. You talked about the long non-coding RNA and its role in cardiovascular regeneration and health. So tell us a little bit about that, long non-coding RNA and diabetes.
Okay, so link RNA, or I'm just gonna call long non-coding RNA link RNA from this point on. So there have been a lot of studies, not only ours, showing that as transcriptional products, link RNAs are regulated in disease versus health conditions, including cardiovascular disease and including peripheral artery disease. And in diabetic condition, the metabolic derangement can alter many of the long non-coding RNA expression. And we identified this link RNA term, the lean, actually in collaboration with you, John. We found that this link RNA is downregulated by diabetes, and it plays a role in promoting angiogenesis. And we have some evidence showing in the diabetic-related peripheral artery disease, this link RNA may be aberrantly regulated together with other link RNAs. Briefly, link RNAs can be modified by lifestyle changes or metabolic diseases, and these changes can contribute to the development of vascular inflammation as well as impaired vascular regenerative capacity, specifically angiogenesis. And they can, for example, this lean RNA bind to the chromatin regions that encoding VEGF, vascular endothelial growth factor receptor, as well as eNOS, endothelial nitric oxide synthase, which are key regulators in endothelial function and angiogenesis. And the impairment of these pathways can contribute to the functional impairment driving peripheral artery disease. And meanwhile, if we find a way to rescue or restore these machineries, we might have some new targets or strategies to ameliorate ischemic tissue regeneration, as earlier discussed.
It's an interesting concept, right? That you got this non-coding RNA that can alter the chromatin. It forms structures, I guess. It binds the chromatin. And what does it do? Does it bring other factors to the DNA to activate genes? How does that work? How does the long non-coding RNA actually function to change gene expression?
So there's no short answer or one-size-fits-all answer to describe how link RNAs may work. I'll stick to this example that we worked with. So the link RNA lean that, as I mentioned, promotes the eNOS and VEGF receptor expression in endothelial cells. They can bind to the DNA regions driving these genes, specifically the promoter regions. And you're right, they also seem to recruit or maybe recruited by RNA binding proteins that bind to chromatin. And we found there a protein called Leo1, which is important to bind to the RNA polymerase to drive the transcription. And likely there are other proteins that participate in this process.
Mm-hmm. So this
and there
part-
are there's other examples showing that link RNA can also recruit epigenetic factors that may suppress gene expression. So link RNAs may promote gene expression, or they may suppress gene expression by working with the cofactors or transcriptional factors that regulate gene expression. And this is among many machineries that link RNAs may utilize. And I also just want to toss it there for interested audience that link RNAs does not only work in the chromosome, in the nucleus, they could also be in the cytoplasm. So an interesting group of link RNAs are circular RNAs. And I think some colleagues at Houston Methodist are also working with this intriguing group of link RNAs. So they can function as a microRNA sponge, and through this mechanism, they can regulate gene expression in the cytoplasm, particularly the translational process, for example.
So I have a simple question. Who's the boss?
Who's the boss of
Yeah,
the cell? Who's the boss?
So as clinicians, which we don't know too much about all this stuff, we always picture DNA being the boss. DNA carries all the genetic material from parents to child, is a big boss. It then uses RNA as the slaves that go out there, following the instructions and go and build proteins or knocks out this out, or so it's a big controller. But now I'm learning that epigenetic factors actually can modify DNA, can actually modify the RNA that the DNA is expressing. So now who the heck is the boss? How these things happen? I mean, are these random phenomenon, or is there some actual controller of all these epigenetic factors that in an individual patient occur different to another patient, and creates all these fascinating things we're listening to?
It's fascinating, and you're absolutely right. It's gotten a lot more complicated because the DNA, like you said, that actually encodes who we are. But the epigenetic factors that are acting on the DNA to cause one gene to be expressed and one gene not to be expressed.
But these are factors that are produced by environment, or?
Great question. And diabetes influences long non-coding RNA, right? So epigenetics is influenced by diabetes. Talk us through that.
Let me go back a bit on this very interesting question imposed. I was thinking to give an analog. So we're not understanding of non-coding RNA or epigenetics does not change the central dogma from DNA to RNA to protein. So DNA are either we call it a boss, or it's the headquarters that make decisions. But the decision needs to be achieved by people or mediators or messengers, and they have to be regulated. So these non-coding RNAs, they act as messengers to relay the message sent or command made by the nucleus DNAs. And I also want to, not to make things more complicated, mitochondria also has DNA. And mitochondrial DNA can also be transcribed. And there has been many reports showing that mitochondrial DNA can be transcribed into long non-coding RNAs. And we have a paper that's just accepted today showing that the mitochondria-derived link RNAs may have a role in talking to the nuclear DNA. So again, it's a regulatory process. And put this in the context of diabetes. One of the most prominent culprits in diabetes is hyperglycemia and the metabolic derangement. So when the cells are going through this metabolic disruption, methylation or methyl groups, a set of groups which are metabolic products, they are misregulated. And they are also the substrates for epigenetic regulation. For example, DNA methylation uses methyl group, histone acetylation uses an acetyl group. So although the DNA are the same, but the environmental factor, metabolic state changes in diabetes can rewire the epigenome to tell the DNA to be differentially transcribed, translated, and to do things that it was not supposed to do, and it was in check.
There was one.
So I hope that it provides a better, another perspective on DNA, RNA, which one being the boss. They're absolutely important.
I have had something you just said reminded me of another one of our articles that we had in the journal.
Yes.
That was the article by Narkar. So you were talking about how epigenetics is influenced by the environment. So the environment has a direct effect. In this case, you're talking about diabetes, but the environment or environmental factors or metabolic factors can affect our gene expression.
Right.
And Dr. Narkar had a paper in the journal about how exercise can affect our cardiovascular system. He focused on angiogenesis and vascular regeneration. And I think that your long non-coding RNA activates NO synthase, which activates angiogenesis. What is the role of your long non-coding RNA in, or what is the effect of exercise on your long non-coding RNA? Do you know?
Great question, and this is one of my favorite topics, scientifically and also personally. So we don't have direct evidence showing what is the effect of exercise on this link RNA in particular, but shear stress that mimics one component of exercise. That's the tangential force imposed on endothelial cells by blood flow. We do have data showing increased shear stress can increase this link RNA lean that promotes eNOS expression. And in animals, in mouse models, when we look at thoracic aorta versus aortic arch that have different flow patterns, we do see the thoracic aorta that's associated with the laminar postulatal flow without much disturbance, which induces eNOS and is anti-inflammation. It induces lean link RNA levels as well.
Nice, thank you for that. Another vascular system that we don't talk about much are the lymphatics.
Oh, absolutely.
Yeah, and maybe we'll turn to that for just a moment. We had a nice article about the lymphatics in the heart. Don't think about that.
We never think about that.
Right.
Yep.
And so we had a very nice paper from Ina Bai about the importance of lymphatics in cardiovascular regeneration. So after a myocardial infarction, I didn't know this. The lymphatics are increased in expression in the heart. There's an increase, there's a growth of the lymphatics. And what's going on there is that they're removing
edema,
proteins that have been damaged.
Junk.
Yeah, junk. They're removing junk. Also the white blood cells.
Yeah.
There has to be some egress of the white blood cells at some point.
At some point.
You have to reduce the inflammation. So you have an increase in lymphangiogenosis. At least in animal models, you block that lymphangiogenosis and you get a worse injury from a myocardial infarction.
It makes sense. Absolutely.
Yeah.
Yeah.
I had a practice at Stanford where we saw a lot of patients with lymphedema, and one of the things that we were very interested to do was to induce lymphangiogenosis to see if we could improve those patients. Jen, have you done any work on lymphangiogenosis? What is the role of nitric oxide in lymphangiogenosis, long non-coding RNA? Sorry to put you on the spot there, but I was just wondering if you had some thoughts about that. You succeeded
in that for sure. This is one of our recent interests in the lab. So we started looking at lymphatic endothelial cells as well, but we're still at a very early stage. We are looking at how long non-coding RNAs are expressed in the lymphatic endothelial cells. And one of the things that we're trying to find is what any difference between the typical like macrovascular endothelial cells, arterial endothelial cells versus lymphatic endothelial cells, because structurally as well as functionally, these endothelial cells are very different. I do not have much insight on Link RNA and the nitric oxide regulation in the lymphatics at the moment. I think in general, the field is still very young. And NIH is very, very interested in this new area for sure.
It is, but when we're thinking of cardiac regeneration, we think of cardiomyocytes, but obviously there's other portions of the vasculature that need to be regenerated as well. The lymphatics, that's not something we get much, draws much attention. But cardiomyocyte proliferation is going to be necessary for true cardiac regeneration. So tell us a little bit more about cardiomyocyte proliferation, Francisco. And I mean, you obviously are getting it done. You're getting cardiomyocyte proliferation in vitro. Why can't we increase cardiomyocyte proliferation in vivo in our patients?
Yeah, so cardiomyocyte, are terminally differentiated, and it's kind of like the human heart, I think, regenerate like 3% a year. It's a very small number. It regenerates a little bit, the cardiomyocyte, but all the structures to form, kind of the mitotic spindle that allows the cell to separate, that is the centrioles, those are disassembled in adult cardiomyocyte. So the cell cannot divide, it won't enter in mitosis, and only that small percentage can do it. So kind of therapy is aiming to increase that population of cells or to deliver another population of cells that can differentiate in cardiomyocyte. I think that is what everybody's trying to do, or a cardiac graft of mature tissue that you can generate in a lab, but the potential of arrhythmogenesis is high, and kind of I think those are the three avenues: endogenous regeneration, inject cells that could regenerate cardiomyocyte, or go in a graft that is generated in the lab. But it's difficult, and probably is this immature cardiomyocyte that they can generate arrhythmias if they couple with the tissue that is mature. And as you mentioned before, in zebrafish or in mice, there is regeneration. In mice, it's limited to the early stages. I think that is day 14 after birth, that you have kind of a second wave of cardiomyocyte proliferation, and then no more. And in human, of course, is also kind of different. It's not proliferating as much as the animal model.
What factors do you add to get the cardiomyocytes to grow? So now for the IPS differentiation, of course, you will induce this layer that I mentioned before, that is mesoderm, and then go to these cardiac progenitors. But there is limited proliferation also in vitro. You can generate, to make it simple, from one plate of IPS, you get one plate of cardiomyocyte. So from 1 million. But there is a paper from Sean Wu last year or 2 years ago that they found that if you activate one pathway, that will make the cardiomyocyte proliferate literally like crazy. So you can generate 100, 250 fold of the cardiomyocyte. So one plate, 250 is a very good method. And what they do is modulate the same pathways that promote the differentiation of cardiomyocyte. That is a signaling pathway that is in the cells that is called the Wnt pathway. And if you activate the Wnt pathway in vitro, you can generate many. That being said, it's not that it will happen, in vivo. These are cardiomyocytes that are kind of immature, and they can have unlimited potential to proliferate. But discovering pathways that promote cardiomyocyte proliferation, it could be important to stimulate the endogenous proliferation that we have in the heart. So yeah, absolutely. Mike, you know, we have this Center for RNA Therapeutics here.
Right.
And we get asked by folks to make RNA for different purposes. And we got a request from Boston Children's Hospital a couple of years ago. And they, speaking about pathways that can activate cardiomyocyte proliferation, they found that the YAP pathway, so YAP is a transcriptional factor that can activate cardiomyocyte proliferation. They asked us to make mRNA encoding that factor, actually a mutant of that factor that was constitutively active. It was always active. And so we made the RNA for them and shipped it off to them. And they ultimately were able to show that that mRNA encoding that transcriptional factor could activate cardiomyocytes, and in a model of ischemia reperfusion injury in the mouse could actually cause cardiac regeneration, could improve cardiac function in those mice. So I think it's, you know, it's, as you were saying, there's probably some pathways that we could potentially act on that would enhance cardiomyocyte proliferation.
The problem is that most pathways for proliferation also they make other cells proliferate. So need to be, and that can be a problem.
That's true.
That could be the good, the bad, and the ugly.
Yeah, so you don't want fibrosis, you don't want cancer, but you want cardiomyocyte. So it need to be specific, and that I think is a challenge to identify pathways that only promote, or methods of delivery, you know, kind of locally to the heart that stay there and they don't go someplace else.
You know, I just thought of a situation where you don't want the heart to grow. That is in the xenotransplants, the pig hearts. You know, they modified. So I think Dan Gary, who was going to be one of our guests today, wasn't able to make it, but he's done some work with the xenotransplants, the pig hearts, and others are doing work. But the pig heart is actually larger than a human heart.
Right.
And so when they made these genetically modified pig hearts that didn't have, I guess, the MHC complex, so they wouldn't induce an immune response, and there were some other modifications. One of them, they made like 12 modifications. One of the modifications was knockout of the growth hormone receptor, so the heart wouldn't grow too big. Yeah, so that was kind of interesting. I don't know where that is right now. Do you know anything about that genetically modified heart transplant? I thought that was interesting.
So I hope we have spared the interest of clinicians to listen to this fascinating webcast. But anybody who's listening, including myself, I mean, our interest as clinicians in this fascinating topic is because we keep looking ahead for the hope that this will become a form of therapy. So I'd like to kind of throw in the last question. Number one, it's looking, at least from what, in fact, from one of the articles in the journal, that was the stem cell therapy, a promising option for patients with chronic limb ischemia. It looks like perhaps possibly the vascular arena might become the first arena where fruitful developments will happen within at least our lifetime. What do you say, 10 years or so? That potentially this type of therapy could be routinely used for people with significant vascular disease?
I think that we're getting closer to angiogenesis, to restoring the microvasculature. I'd be interested to hear what Jen has to say for peripheral arterial disease. But we've got some growing evidence that heart failure recovery is a vascular recovery. We've got evidence from our own work. And that's fascinating, because when we think of heart recovery of the heart, we think of the cardiomyocyte, right? We forget about the non-myocytes, and the non-myocytes play a really important role in supporting the heart.
So again, you know, I know that it's hard to do anything, but I mean, are you thinking in terms of something that's going to take us 20 more years, 50 more years?
I think we can get there faster by understanding the pathways that are involved. And we may be able to manipulate those pathways with small molecule agonists or antagonists, or with mRNA. I think there's a lot of possibilities for mRNA. Of course, I'm a little bit biased because that's something we're studying a lot these days, but mRNA is like biological software. So you can basically, if you need a particular protein in a cell. All you have to do is write the code for it with the mRNA. Of course, then you have to deliver it, and there's some difficulties there, but we're working on those.
So as you look ahead, again, it could be 20 years. As you look ahead as heart diseases, what do you think will be the first breakthroughs that we'll see? Acute MI, the cardiomyopathies, some of the congenital diseases. Where do you see that potential for having the first major breakthrough where regeneration will become a therapeutic option?
It might be heart failure, and we certainly need new agents for heart failure, right? We've had a lot of good therapies for prevention of coronary artery disease and for treatment of myocardial infarction. We're lagging behind a bit in heart failure. I think it's time for a breakthrough there.
What about the? I'm sorry, you wanted to say something?
No, I wanted to mention also that probably related with RNA, these papers that if you deliver vaccines with the CAR T cells and fibrosis in heart failure, this paper is from Epstein.
Right.
Maybe you can explain.
This is, John Epstein at University of Pennsylvania has created mRNA modified T cells, CAR T cells that can reduce cardiac fibrosis. And I know that they're now moving that toward therapeutic
That could
approaches.
be very, very helpful.
Yeah.
Absolutely.
And the regeneration is basically restore the homeostasis of the tissue, restore the same key components, and preserve the balance. If you have fibrosis in between, you will have uncoupling of the myocytes, right? But if you can eliminate that fibrosis and reconnect those myocytes, maybe those therapies can help to do that, or to make cardiomyocyte to proliferate. That is more difficult.
Yeah.
So how about inherited cardiomyopathies? For those that we already know some of those genes, am I speculating, or is it possible to develop an RNA vaccine that would potentially go there and do what it has to do to knock out that particular gene?
Yeah, there's actually there's a lot
before
of interest
the disease expresses, in the child or whatever.
In gene editing to for example, like Duchenne muscular dystrophy.
Okay.
Gene editing is a potential approach. Also, therapies, small RNA therapies to change splicing. You might know something about this, Jen, about the small RNA therapies to alter the splicing of the RNA in Duchenne's disease to restore normal function. Anyway,
that's as much as I know about.
Yeah. So I think there's approaches using small RNA to change the way the RNA is spliced that encodes the proteins.
So as we look, again, as clinicians, as we look at the future, potentially some of these developments may actually be helpful in prevention. Before the cat comes out of the hat, or the rabbit, hit the young patient at a time, and hopefully prevent the phenotypic expression of a particularly with genetic diseases, but we know the gene, so we can.
Absolutely.
Is that science fiction, or is that
no,
something
not at all. I mean, inclisiran is an example of a nucleic acid therapy that lowers familial hypercholesterolemia. That's approved.
Right.
So I think
exactly.
We already have disorders. That are treated with nucleic acid therapies. And I think that the ability to basically write the code using nucleic acid therapies is going to really broaden and rapidly increase the development of new drugs, get them to the clinic.
Fascinating. Can we check if we have any questions from our audience that we may want to ask our outstanding presenters? Well, if we don't, I want to again thank you all for participating. Dr. Chen, thank you so much for being with us. And again, to our viewers, I want to encourage you to read this journal and also read all of our issues. As you know, we are increasing also the publications of exciting case reports. So feel free also to send us your interesting cases, and we will review them. And if they if they meet criteria, we will publish them and continue to enhance the educational value of our journal. So thank you very much, and all of you have a good night.